So, Assalamualaikum. I am again here, DrNAS, with you guys, and today we gonna do the last but not the least topic of aortic regurgitation. So, in management of aortic regurgitation, first of all, we have to keep few things in our mind. Number one, the stages of the AR. That stage A, obviously, as we learned earlier, that it would be the on risk, and B, it should be like moderate and mild, and C would be asymptomatic severe AR, and D would be the symptomatic severe AR. So after staging of the any particular disease, but now we are here concerned with the AR, so we will discuss about the stages of AR. Okay, so according to the stages of the AR, you have to look for the risk factors if your patient is at risk to develop the AR, but we don't do anything. But those patients who would have moderate AR, then we need to intervene in a certain situations which we will discuss later on. Now, the most important thing is what to do with AR and what to not to do with AR. So number one, you have to decrease the afterload. It is for sure. Why? Because when you will decrease the afterload here in aorta, if for suppose something is the force, is there any force which is like if there any force which is hampering the blood flow towards aorta, then what would happen? Obviously that wall is not patterned. The most of the blood comes back to the LV, and it causes the worsening of the AR. That's why you have to keep aorta open. You have to reduce the afterload. You have to relax the aorta so as the LV easily sends blood to the aorta. If you will not relax that aorta, if you will not decrease the afterload, then what happens that the most of the blood which LV send to the aorta will send back to the LV. So what will happen then? Obviously it would worsening the AR, it causes the increased preload here, and that blood goes back to the LA, and it increases the pressures, venous pressure of the your pulmonary arteries, and it would pulmonary vessels. So what it would cause? It would cause the acute pulmonary edema. Okay, so the treatment which we are going to discuss here is the most of the treatment of chronic AR. It's not the treatment of the acute AR. Got it? Why? Because in the chronic AR, it is a class 1 to do the surgery as soon as possible. There is nothing to do with the acute AR, with the medical treatment, all these things. Yes, but before sending patient with the acute AR, you have to like make them stable for sending them to OR or OT. Okay, so the important thing, rule number one, to manage the AR, the chronic AR, you have to decrease the afterload, you have to relax the aorta, and by that afterload reduction can be achieved with ARBs or ACE. They are the best afterload reductors. So the best thing to choose for decreasing the afterload is ARBs or ACE. But keep one thing in your mind, that ARBs and ACE are not going to decrease the progression of AR. They just decrease the afterload, but they will not progression of AR. But only one condition which is proven in certain studies, that if your patient has is Marfan syndrome and he or she has AR because of the dilated aorta, so in that condition you can give ARB or ACE to decrease the afterload, and it will give some mortality benefit to those patients. Why? Because in that condition, because of the fibrillin gene involved in the Marfan syndrome, it decreases the progression in the patients of AR with Marfan syndrome. But if your patient is a simply AR, like simple or the plain AR for any condition or for any reason which is not Marfan, so ACE or ARB will not decrease the progression of disease. Okay, got it? So rule number one is to decrease the afterload with the ACE or ARB. Number two, you have to give diuretics if needed. If needed, you are not going to give the diuretics in routine to your patients of AR, and as soon as possible, if it is indicated, which we will discuss later on, that your patient is the if your patient has an indication to do the sever or intervention, then you will not make wait to your patients, but you have to send them as soon as possible to the surgeons for surgical aortic valve replacement. Okay, beta blocker, ACE inhibitors, and the diuretics. If ejection fraction is low, then you have to treat them accordingly. But in the AR, we are not going to control the rate with the beta blocker, but as we were doing the afterload reduction with the ACE or ARB. So the first drug to add on or to start in the AR is ACE, not the beta blocker. Why? Because when you will decrease the rate of the LV or the contraction, like if you will increase, when you are controlling the rate, it means that you are prolonging the diastole. If you prolong the diastole, then the filling of the heart, with blood from LA to LV will increases. So as much as blood will be in the LV, so it will send the more blood to the aorta, and obviously the more blood will come back to the LV. So if you prolong the diastole, it will cause and it will increase or it will worsen the AR further. Okay, so it is very important that not to control the heart rate in the patients of AR, but you have to keep the heart rate of your patients like in 80s or 90s. You will not strictly control the heart rate in the AR until and unless your patient has the low ejection fraction, all these things. And according to the, if your patient has a low ejection fraction, again you have to control the rate very cautiously in the patients of AR. But beta blocker, ACE and diuretics will remain class 1 if your patient has a low ejection fraction secondary to AR. So you have to treat the blood pressure if it is more than 140 systolic, and it is class 1 indication that you have to treat the patient. Why? Because if the systolic pressure is higher, it means that there is an increase afterload in the aorta, which you have to decrease, as we have discussed earlier in the afterload reduction section few minutes back. Now come to the don't. What are the things which we are supposed not to do with the AR? Number 1 is never ever leave your patient on medical treatment in the expectation that progression of the AR will decrease or your patient will better. No, never ever. The mortality will be increased if your patient is symptomatic and having the severe AR. Then you have to control, you have to send them to the surgeon for controlling the symptom of AR for the surgical AVR, because without surgical AVR your patient not gonna be okay, not gonna be asymptomatic on medical treatment, because medical treatment is not the option of not the choice to treat your patient with AR. It just gives the symptomatic relief or it just make them stable, but it will not decrease the mortality and overall health of your patient. Okay, now come to the no IEBP. It is one of the class 3 indication of IEBP if your patient has AR, like aortic dissection. Like if your patient has aortic dissection and as well as AR, because of the aortic dissection, the both things are class 3. If your patient has isolated AR, severe AR, you are not supposed to do the IEBP. Why? Now you will ask why. Because in IEBP, what happens that the balloon inflates in the diastole. Balloon inflates in the diastole, and in diastole, what happens? That after the systole, in the diastole, when blood comes here, what's coming here, then aortic balloon inflates and sends back blood to the here in LV. In normal condition without AR, what IEBP does, that it increases the coronary perfusion. It sends back blood back to the sinuses, so it just gives the filling of the coronary artery. But in the severe AR, what happens that because of the ill valve, because of the less patent valve, the valve remain open, and when that blood comes back to the sinuses of Valsalva, it will not go into the coronaries, but it comes back to the LV and causes the worsening of AR, and it will further worsen the your LV and diastolic pressure and causing the acute pulmonary edema. So it is class 3 indication, like it is contraindication to put the IEBP in the patients of AR. Don't make bradycardia, as we discussed earlier. As well as you will do the bradycardia to the patients, the diastole will be increases and the regurgitation will be worsened. No TAVR. Why no TAVR? Because TAVR, again, severe or moderate to severe AR is one of the contraindication of the TAVR. So no, big no of TAVR to the patients of AR, and no percutaneous. Up till now, there are few treatments which are advised or are undergoing in like in research that so a big no to the percutaneous treatment. And number two, that nothing has been recognized and has been recommended from ACC or AHA or ESC that AR should be treated with percutaneously. But few are the things like have been done or are under research, that those are the transapical treatment of the AR. But no need to discuss all these things because it will just make you like confused and make this lecture complex, and I don't want to make you confused, guys. I just want your concepts to be very crystal clear. That's why I just leave all these things here, just to remember one thing in your mind, that there is no percutaneous treatment has been recommended from anywhere, like in our guidelines from ACC or ACCA or AHA. But now the important thing is that timing of intervention, when we need to intervene. So all these for the intervention or for the timing of intervention, if you just keep one thing in your mind, then the timing will be easier for you guys. Number one is 50-50. What is the meaning of 50-50? That just remember the name, number 50 and 50. 50 is the ejection fraction, which now turned out to be 55 in the new guidelines of 2020. But again, I don't want to make you confused. So many books have written still 50. So if you are remembering number of 50, then it will not be false for you guys. So just remember that 50-50, and the best student can remember the number 55-50. So 50-50, what is the meaning of 50? If the ejection fraction is less than 50, then it is class 1 to do the intervention in your patient. And if it is LV systolic dimensions are more than 50, like 150 is less than, and second is like one is less than and one is more than. So this is the EF and this is the LV systolic dimension. So if the LV systolic dimension, like if your heart is dilated more than 50 LV systolic dimension, then it is class 2A indication to go for the AR or surgical AR. And if your patient has ejection fraction of less than 50, then again it is class 1 indication to treat your patient with surgical AVR. So if you are not going to remember, if you are like if you have a very weak memory like me, then you can remember just two things in the timing of AR. Okay, so for the detail and for those who just want to make it perfect, then for those like severe AR, then you have to divide the severe AR into two categories, symptomatic and asymptomatic. And severe AR, just keep all these things in your mind of the which we discussed in our previous lectures of echocardiography, the regurgitant fraction, the regurgitant volume, ERO, and the jet area and vena contracta. So all these things are explained by echocardiography, that your patient has a severe AR and you have and your patient is symptomatic. Then if your patient has, even though if your patient has normal ejection fraction, you need to do the what? You need to do the surgical AVR. It is class 1. So if your patient is severe AR, nothing to do with, and if he or she is symptomatic, just straightforward go with the surgical AVR. Now the problem is with the asymptomatic, because in most of the exams and most of the time examiners does not ask you about the symptomatic AR, because everybody knows that if the symptoms whenever the symptom come, you need to treat the patient. When to treat in the asymptomatic is an art of cardiology. So in asymptomatic patient, as I told you, if the ejection fraction is less than 50, you need to treat it as class 1, and if the LV systolic dimension is more than 50, then again you have to treat it as class 2A. So now the important thing, so this section has been covered with this 50 ejection fraction, and this section also has been covered with this 50. Now the thing remain is that if your patient has severe AR and your patient is asymptomatic and he is supposed to go for another surgery or for cardiac thoracic surgery, then it is better to fix that AR with the surgical AVR. It is class 1 indication. So it is very necessary if your patient is asymptomatic AR and he or she is going for another surgery, you need to fix the AR with the surgical AVR. Now, if your patient has a progressive AR, what is the definition of progressive AR? If on 3 studies your patient has LV diastolic dimensions are more than 65, and if he or she has the less than 55 or 60 ejection fraction, then you need to do what? You need to do the surgical AVR, but in the condition of low surgical risk. If your patient has not low surgical risk, then do not go for the surgical AVR in your patients who has the progressive AR, because it is class 2B. We are supposed not to leave our patients without treating a class 1, and if you are practicing class 2A, it means you are a good doctor, and if you are practicing 2B, it means you are doing what? You are just following the pocket guidelines, because 2B is known as pocket guideline. Okay, so we usually don't practice 2B, but you have to keep things in your mind. If you are just want to remember 2 things in your mind for the timing of intervention, just remember 50-50 in the AR. If your patient has moderate AR and he or she is going for the other surgery related class 2A again to treat the patient with the surgical AVR, if your patient is already going for another surgery. So this was all about the management of AR. Just keep one thing: 50-50, less than ejection fraction 50, you need to treat it class 1. If it is do not remember class 1, class 2A. Just remember that when to do, how to do, and why to do. Okay, so just keep it. But if I'm just telling you guys that it's class 1, 2A and 2B, why? Just to emphasize you that you need to practice class 1. You do not need to practice class 2B in very frequently, and you are not supposed to practice class 3 because it is contraindication. I'm just making you guys familiar with the guidelines which you're gonna read after my lecture. So 50-50, okay? The timing of intervention is 50-50, do's and don'ts, nothing else. This is the management of AR, and we are done with the AR right now. Go and read the whole topic in your box, and yes, before going that, do not forget to press the bell button and subscribe to YouTube, my channel, and spread this word, spread this knowledge, spread those lectures in the world as much as you can. Thank you, take care, Allah Hafiz. It's your DrNAS.